Hi there, I'm Susie Hudson. I'm the Clinical Director here at NADA, and I'm here to welcome you to another fabulous webinar as part of the Community Mental Health and Drug and Alcohol Research Network. We really thank you for joining us, and today we're going to be specifically focused on looking at evaluating service changes due to COVID-19. I'd like to start by acknowledging the traditional owners of the land on which we are today. Here at NADA, it is the Gadigal land of the Eora Nation, and welcome you from whichever land you are joining us from. And to pay my respects to elders past, present, and to future generations. It gives me great pleasure today to introduce to you our speaker. It is Professor Anthony Shakeshaft. He's the Deputy Director at NDARC, the National Drug and Alcohol Research Centre at UNSW. And among many of the wonderful things that he's done is really to work quite closely alongside a lot of our member organisations and community groups, non-government and government, to really assist and support people who are on the front line, both mental health and drug and alcohol, to explore their data, to really look at whether their practices are effective. So he's in a great place today to really help us explore how we can really measure some of these service adaptations. So without much further ado, I'm going to hand over now to Anthony. Welcome, Anthony.
Great, thank you, Susie, and thank you for that lovely introduction. I'd also just like to thank the network for inviting me to present this webinar. I think, you know, as everyone will be aware, there's some very challenging changes to service delivery as a consequence of COVID-19. So, you know, along with those challenges comes opportunities. So, as Susie mentioned there, some of the opportunities that I'm hoping to explore during this webinar. I'd also like to acknowledge the Aboriginal people of the area where I live, which is the Bidjigal people, also of the Eora Nation. So pay my respects to them, their elders, past, present, and future. The other thing I should do before I go too far is apologise for my hair. I've been stuck in isolation like everybody else, and the barber's been closed. So hopefully it's not too distracting. Right. So let's, sorry. Right, that's what I was looking for. So let's get moving. So what I want to talk about is what we can learn from COVID-19. So as I've mentioned, everyone's acutely aware of the dramatic changes in the delivery of mental health and drug and alcohol services that COVID-19 has forced. And I think there's two key opportunities that it's presented. One of them is to systematically document and assess the impact of the changes to service delivery. And to assess the impact of COVID-19 by establishing an impact framework that could be used routinely by services to measure the impact of any future changes. So one thing we could do is kind of think about COVID as a one-off event and think, well, if we can just sort of document how we've done things differently and what some of the impacts of that might have been, and then, you know, put that to bed and move on to the next thing. That's one way to approach it. But I think if we're going to go to the trouble of trying to understand the impacts of COVID-19, then there's a real opportunity to think about actually, how do we set up a kind of system or a framework so that we can understand, you know, whenever there's future kind of shocks to the system, if you like, so that, you know, doesn't have to be a pandemic. It could be things like a big shift in policy, perhaps the introduction of a new, you know, fantastic treatment. So those things that have kind of big implications across both the drug and alcohol and mental health services sector, how we can set up a system so that we can, in real time, or in as close to real time as possible, routinely monitor the changes that those sorts of, you know, big level shocks to the system might have. So there's the, you know, the Winston Churchill line about never letting a serious crisis go to waste. And I think a guy called Rahm Emanuel, who was the, I think he was the mayor of Chicago or something, And he kind of added to that by saying, you know, one of the things about crisis is they give you the opportunity to think about doing things in a way that you either hadn't had the opportunity before or you didn't think was possible before. So, and I think that's certainly been the case this time. So clearly understand what's changed in the delivery of each of the programs and services. So that requires, ideally, whether it's, we're talking mental health or drug and alcohol services, it really needs that to be done in a standardised way, because otherwise, if we say, you know, a particular type of service delivered through the drug and alcohol services, for example, if we're comparing across different services, we need to be really careful that it's a consistent change and not just a difference in the way it's been recorded by different services. It's going to be really helpful and important to be explicit about how each program is now delivered, post COVID-19. And there's also an opportunity to think about how we might use data that all of the services, both drug and alcohol, mental health, collect routinely anyway. And we'll talk a lot more about some of the implications of those data. But obviously there's the minimum data sets that both services collect. So I think one of the critical things is, if we're going to establish this kind of a framework, we don't want to be turning around to the services and saying, oh, to do this properly, you need to collect another 10 measures, or, you know, got to ask another 20 questions. I think probably everyone's reasonably comfortable that services have to do enough assessment as it is. So we don't necessarily want to add to the burden of collecting that information, but what we want to get much better at is using that information that the services collect anyway. So here's what a framework, one way to think about a framework. This is essentially a program logic, and one that we've been working with NGOs over quite a long time to develop and refine. And it really came out of doing some work about trying to define what it is that services provide. So when we first started doing this, you know, we were working with a couple of services and it was relatively straightforward. So, you know, what kind of service you're providing, what are the components of it? But when we then took it to other services and we said, so these services are delivering, you know, their detox or their day counselling programs like this, is this something that you could do so that we can have you could also do so we can have a standardized process across multiple services? And inevitably, or almost inevitably, the answer was, well, some of that we can do, but some of it we can't, because we have different types of clients, we're at different circumstances, we've got different staff with different interests, we're at different geographical locations. And so all of that became a sort of, everything would just grind to a halt in terms of what we're trying to do, because we'd be trying to say, you know, well, there's some evidence that this represents best practice. Services are implementing, some services are implementing like this, but we can't get that delivery of services standardized across multiple services. So we really started to think about how we might do that. And this is the framework that you can see on screen now, is the one that we came up with. So I'll just talk you through each of the components of it, and then we'll go into a bit more detail to help you understand it a bit more clearly. So the first one is in the first column there is the outcomes of interest from the COVID-19 changes. So that's really just specifying what it is that you think might have changed as a consequence of the changes that you've had to make to your service delivery. So what are the key components of your services? What are the mechanisms of change for each of those components? So the reason that's important is because it's trying to say, if you're delivering a particular component of treatment, so it might be, you know, 6-week day program of CBT, then a critical question is, how is that likely to improve outcomes for clients? And it can be challenging, but it's really trying to think through, of all the things we do, you know, we do a standardized assessment with clients and then we deliver a program. So what's the point of doing the standardized assessment, and how does that, by what mechanisms might just doing the assessment process lead to some sort of change for our clients? So that's trying to specify what those are. The next box is how is each treatment being, a component being delivered in practice. So this is the one when we initially did this, this was just one column. And the idea was to say, you know, a service, a drug and alcohol day counselling program that's being delivered in, you know, Burke, might deliver the same components as one that's being delivered in Surrey Hills in Sydney, but the way it gets delivered is very different. So the idea of this, how is each treatment component being delivered, is to think through, you know, a critical part of treatment provision is assessment or doing some kind of, you know, evidence-based counselling program, but the way that gets delivered and the way that's implemented can vary across services. So the idea of that next column is to think that through. And then the before and after COVID is the opportunity to think, so how do we used to do that? How do we used to deliver the assessment and the, you know, the treatment programs, and how do we do it now? The last two columns are about measuring change. So one of them is the processes. So traditionally that's things like how many clients complete treatment, you know, are they happy with the treatment they received? So they're the kind of things I mean when I talk about processes. And then the outcomes are, you know, things like, does it actually improve client outcomes? So quality of life, reduce drug and alcohol use, improve mental health, whatever it might be. So let me try to illustrate that now, each of those components with some examples. So in terms of the outcome of interest, examples might be client retention in treatment. So the question would be, or a potential question is, as a consequence of the changes that have been forced by COVID-19, has it changed the number of clients who are retained in their treatment program, or the period of time for which they've been retained or they can be retained in their program? Has it had any impact on things like successful treatment completion? Does it impact on Aboriginal people more than non-Aboriginal people, or, you know, women more than men, or younger people more than older people? And then have treatment costs changed? So there's some of the sort of questions that could be asked. This is in terms of trying to think through that middle section. So what are we actually delivering? So the first, you know, this is just a sort of hypothetical example, but the first key components of the service, you might say a service has, and, you know, I think this would be true whether it's drug and alcohol or mental health. So you might say a service has got 4 key components. One of them is the assessment process. The second one is the counselling, actual counselling program that gets delivered, which in this hypothetical case might be 8 weekly sessions of trauma-focused CBT. There's a discharge process and a follow-up process. So they're the 4 key components of this treatment service. The next column looks at the mechanisms of change for each of those. So, you know, the point of doing an assessment process, for example, might be that it allows us to tailor treatment to the particular needs that are identified for different clients. In terms of the counselling program, the way that 8 weeks of trauma-focused CBT might help is because it's an evidence-based treatment that helps clients understand and respond to their dependence and related issues. And the same for the discharge process. So it helps clients think about what they're going to do and how they're going to cope when they're back in their usual day-to-day lives without the support of counselling or treatment. And then the last one is, you know, whether there's some progress to check on clients, you know, a cost-effective way to check on them after they've formally left treatment. So again, now in the last 2 columns, this is how some of the activities about how those things, how those components of care might have been delivered pre and post COVID. So beforehand, all the assessments, for example, might have been done face-to-face. Now services might have decided, well, actually, the ones we can do by phone or, you know, Zoom or whatever, we'll do them that way, and then we can reduce the amount of face-to-face time that we need to have with clients when they turn up for their first sessions. And I won't go through all of those examples, but you know, you can look at those when you get time, but hopefully they're reasonably clear. It's just trying to say the key components of a service haven't changed as a consequence of COVID. The mechanisms of change are the same. The only thing that's changed is the way it's being delivered. And so then the interesting questions that we talked about is whether the mode of changing the way the core components of treatment are delivered, so those sort of service provision activities, whether they have made an impact on the processes and outcomes. So as I mentioned before, processes might be things like the number of assessments that were commenced, the number that were completed. So once you start doing, for example, assessments, I don't know, over the phone, you might find that clients really hate it. And so they kind of get halfway through and they say, oh, I've got to go, and you can never get them done. Or they might love it and it's much easier. So if you can measure an impact from changing the way the activity is done, then that can be quite helpful. And the same with some of the other things. So we talked about there, the number of clients who attend their counselling, does that change if you change the way you do it? And then things like satisfaction ratings. So the last area that we could look at is outcomes, so how they might change, again, as a consequence. And they're things like improved client retention, whether the proportion of trying to complete their treatment successfully has changed, whether there was any differential impact for some particular type of subgroup of clients, so in this case, Aboriginal or non-Aboriginal. As I said before, it could be differences between males and females, different age groups, and then whether there's any net costs. The other thing we'll talk about later is whether there's any actual change in patient outcomes. So that might be things like, do their K10 scores improve more or less as a consequence of having delivered programs differently, or no change. The drug and alcohol services have at least the government services have things like the ATOP. So whether we can actually detect measurable change on that patient level outcomes, we'll get to a bit later. Okay, and you can see there really how the outcomes of interest that were identified in the first column line up exactly with the things that we're trying to measure in the outcomes column. So that's a critical part of this program logic, that when you're thinking through what's the program trying to deliver, what do we think it's aiming to do, and then how are we going to measure that? And if you can't measure, I think I'd go so far as to say, if you can't measure it, then you either need to generate a measure for that, for the outcome of interest, or you could drop the outcome of interest and say, ideally we might like to do that, but we can't measure it just yet. So let's just do these ones that we can measure, and then over time we'll think about how to increase the number of things that we're interested in. Okay, so what are some of the key features of that framework? So most services deliver multiple types of programs. So, it might be a detox program, it might be a day counselling program. So you probably have to do that framework for each of the, not for a service per se, but for each of the individual programs that the service delivers. Another key component of it is that it really relies on the services driving the outcomes that they want to measure and improve. So I'm going to go through an example for you in a moment of some work we've done with some of the services we've worked with, but a key component of it is that the services are really driving the impetus for change. So, I'm a researcher. I know some things about how to evaluate and how to measure things, what sort of designs can be useful under what circumstances, but I really don't know anything about how to deliver a clinical service. So I think one of the key things about this framework is that it helps sort of align the expectations and the understanding of service providers and researchers. Another key feature of it is that it combines process and outcome measures. The next one is that it can be integrated into ongoing continuous quality improvement processes. And I actually think, that's really critical, and we need to get much better at thinking about, how do we measure one particular thing at a point in time? So, we deliver this treatment, along comes a new treatment like, depot buprenorphine, for example, for drug and alcohol clients with heroin dependence. So all of a sudden we've got this new treatment. Does it work better than methadone? So we can do these kind of one-off evaluations all the time, but it's really clunky and it's slow. So I think we'd be much better off if we can find out a way to have continual sort of quality improvement processes within services, and then sort of how do we really build up the methodological quality of evaluating that process, so that there's a sort of constant cycle of modifying things and constantly checking about whether it's changing, either improving outcomes for clients or having no impact on clients but reducing costs. And then the last one there is we could use this sort of a framework to develop new innovations, like the routine delivery of integrated mental health and drug and alcohol services, which I'll talk about some more in a moment. So that's the framework that we could use, and it's certainly something I'd be recommending that we could use as a way of saying, so here's what we used to deliver, and now here's what we are delivering. The core components are the same, or they're not, but it's the sort of activities of the way it's being delivered have changed as a result of COVID-19. So we could just do that as a one-off and then all go on our merry way. But as I say, I think there's a real opportunity now to think about how do we really kind of make this process of continually evaluating what we're doing routine. So the little diagram on the left there, the translation one, is really what we try to do now. So we kind of really think about the practice, the service delivery components, the policy components of what we're doing, and research as separate things. And then we try to do, even if we do a trial of a new drug or a new treatment and it's with services, we tend to put it in a little bubble. So we exclude lots of clients. We only include ones that we think, we're going to be able to follow, all that sort of thing. And then we get a kind of, result, and we say, oh yes, there's a 20% improvement in outcomes for clients who got the new treatment. Now, how do we get the services to take up the new treatment? And of course, then there's a whole other range of factors associated with that we just haven't thought of in that context of translation. So I think one of the things that I've become increasingly convinced about is that model of, doing research over here and then translating it into practice, it can work, but it doesn't work very well. It's not very efficient, and I think it doesn't work very often. So the next one is, how could we do it differently? And that's, no surprise there, but it's really about how do we get better at embedding evaluation into the routine delivery policy and practice. And so to do that, there's a whole range of features that I've listed down the bottom there that we need to get much better at. So things like pragmatic trials and learning systems, which is with the researchers to get better at developing that and explaining how it could work. Perhaps improving the quality of the routinely collected administrative data. So that's things like your minimum data sets. I think there are some problems with them, of course, but there's a lot in there that we could use. The co-design of interventions. So how do we get better at getting researchers, clinicians, policymakers to sit down and co-design those things together? And then the process of, organisational change. So one of the groups that's been thinking about how we might do this, create these sort of or embed evaluation into practice is the Institute of Medicine in the US, and they about 8 or 9 years ago, I think it was, put out this definition of what they're calling a learning healthcare system, and I actually think it's pretty good. So what they mean, or the key features, or what they mean by a learning healthcare system are these. So it's to apply and generate best evidence to support the collaborative healthcare choices of each client and service provider. So it's applying and generating best evidence. It's driving the process of learning as a natural outgrowth of client care. So it's not saying, that we should prioritize research and learning over client care. It's both. Like, how do we organize ourselves to achieve both of those simultaneously? And then how do we ensure demonstrable innovation in quality, safety, and value in service delivery. So I think some of the key principles of a learning healthcare system are those ones there, data and technology driven. So I think we've got to get much better at using data. Continuous learning, organisational culture. So we've talked about that a bit already. How do we build the idea that we're never getting to a point where we're delivering best evidence care? All we're doing is getting to a point where we're constantly trying to incrementally improve what we do. And then the idea of how do we combine the expertise of different groups to co-create what we're doing. So when we first look at this, I had a PhD student of mine, Tanya Pearce, who's based at the University of New England in Armidale. So we worked with her and her director up there, Miff Maple, and others. And we started to think about, well, what do we actually mean by co-creation? Let's get that right first, as part of Tanya's PhD. And that took us about 2 years to work out what anybody means by co-creation. So we ended up, there's all these other terms, co-ideation, co-implementation, co-production. The list is almost endless. So we spent 2 years systematically going through the literature to try to work out what people meant by co-creation. And we think this is a pretty good summary or synthesis of what's been published. So it's a generation of new knowledge that is derived from the application of rigorous research methods that are embedded into the delivery of services or policies through 4 collaborative processes. So generating ideas together, or co-ideation, designing the policy or the service delivery program and the research methods together, that's the co-design component, implementing it, that's the co-implementation, and then collecting the data and analysing it and interpreting it together, and that's the co-evaluation components. So I think one of the key things to point out there is that it's the application of rigorous research methods. So we're not talking about, one of the problems is if we've got one, mental health service or an drug and alcohol service, and they're really good and they're constantly changing things and they're just doing a traditional continuous quality improvement cycle, that's great and it's terrific, but there's no generalizability to that, or you're never going to get enough sort of clients through the service to be able to say something, that makes us really confident that the results are kind of robust and generalizable across other services. So the only way we can do that is to get multiple services working together and coordinating what we're trying to do across multiple services. And so that really needs rigorous research methods. So that's things like pragmatic trials that we talked about before. I hesitate to say this, but I'm actually a big fan of randomized trials. So, but I know they get a bad reputation because they can be sort of seen to be difficult and complicated, but they don't have to be. And there's plenty of ways now of even building in patient, choice. So we can be saying to patients, look, ordinarily, we give you treatment A, there's some new evidence, or as a group of clinicians, we actually think treatment B might work better, but we don't know. So what we want to do is test it. So as part of the service we're going to provide to you as part of your treatment, you can either have what we ordinarily would have done, which is treatment A, or you can have the new one, and if you don't care, we'll randomise you to get one or the other. So there's ways we can sort of build in that choice component to make the evaluation design to make sure it remains rigorous. So there's lots of things we can do, but I think that co-creation, this definition of co-creation, is really critical. Right, so let me give you 2 examples. One is some work that we've done on integrating mental health and drug and alcohol treatment for clients, and the other one is a more recent project on trying to improve the cultural competence of drug and alcohol services in non-Aboriginal settings. So integrated care for mental health and drug and alcohol services. I think this is going to be like selling coal to Newcastle, talking to all of you about the importance of this. The list of people who are involved in this process is endless, but it was led by Dr. Kath Foley, who's based up in the mid-north coast LHD. You can see down the bottom of this slide, there's a whole range of people. So the Mid-North Coast LHD, as I mentioned, Hetty, Lives Involved, the whole group of organisations were involved in this work. And it really came from Kath getting in touch with me and saying, so we're trying to do this model of integrated care. How do we, you know, we want to do it properly, but how are we going to know if it's working? How do we build that evaluation into it? So we worked over 4 years to try to work with her team up there to see if we could work out a process for what we're doing and then how it might be made available for other services to do it as well. So it's all about integrating the specific type of integrated care that they were talking about was integrating outpatient drug and alcohol treatment into mental health inpatient treatment. The why there will come as no surprise. So they, looking at their own data in the mental health inpatient service, identified that they had about 70% of their residents had clinically significant substance use, but when they referred them to drug and alcohol, about 10% of them clients took that up. So that's the problem they're trying to fix. Why isn't integrated care provided routinely? So we hypothesise that there's 2 reasons that this doesn't happen. One of them is that there isn't a standardised model of integrated care that's easily able to be translated into practice across multiple settings. And the other hypothesis was that even if you had that model of care, it's really hard to work out how to actually, like, what are the steps you need to take to get it taken up into practice. So here's the standardised model of care that we developed. And I hope you can see how it's exactly the same as the framework we talked about before, or a very similar version of it. So in that first column, column A, target area. So these are the things that they wanted to do: reduce service gaps, reduce treatment duplication, minimise silo treatment, improve client and staff engagement and empowerment, optimise the number of clients who received integrated care, and optimise client outcomes. So the reason optimise client outcomes is in that orange is because I'm really trying to emphasise that there's a whole range of things that you can measure as improvements beyond just client outcomes. So client outcomes obviously are really important. And at the end of the day, it's the client outcomes where we all want to get to. But you know, measuring those consistently and in a robust way is difficult. And, you know, I think we're slowly getting there. But I think it'd be a real mistake to hold up this process of trying to get better at bringing together clinicians, researchers and policymakers just because we haven't got great client outcome measures yet. As I'm trying to emphasise there's a whole range of outcomes and things we could measure over and above the ideal, which is client outcomes. So what are the core components? These are the core components that they come up with on the mental health and drug and alcohol clinicians come up with. So there were 7 of them. One was that there was no wrong door. So, you know, wherever a client turns up at a service, if they've got co-occurring mental health and drug and alcohol issues, then they should get treatment or access to treatment for that. It means that there needs to be brief, regular screening in both the mental health and the drug and alcohol services so that we can identify who it is that's likely to benefit from integrated care. The therapies, whatever it is that's provided, have to be best evidence. And it's probably worth just noting that, you know, David Sackett years ago in the British Medical Journal, I think it was 1999 or something, wrote a really nice, you know, 1.5-page paper. His group were the first ones to propose this idea of evidence-based practice, and then they got all this pushback, you know, about, oh, you can't just do exactly what the evidence says. And he wrote this really short paper in the BMJ saying, you know, it's not, perhaps you haven't been clear enough, but it really isn't about just doing what, you know, evidence says. What it's about is saying, what does the evidence say, and how do we combine that with clinical experience and expertise? And that's what evidence-based practice is. So it's not just research evidence. It's not just clinicians using their expertise. It's bringing those 2 things together. So evidence therapies, we don't mean going to clinicians and saying you should all be doing X, Y, and Z. It's sitting down and saying, well, the evidence says for these types of clients, this is likely to be effective. How do we, you know, what do you think? How would that work here? How do we, you know, how do we bring the clinical expertise to bear onto that research evidence? The fourth core component was systematic feedback from staff, clients and families. So, you know, making sure there's that constant, not just doing it, implementing something and then all going on our merry way, but implementing something and then constantly having feedback from staff, clients and families about how that's going. Post-treatment care, building collaborative service relationships and having formal links to researchers. So they were the core components for that of integrated care for them. And then I won't go through all the flexible activities, but they're just the ways that they worked out that they could operationalise those core components in the Mid-North Coast. So those flexible activities could be anything. You can do that in whichever way suits you, suits your services, suits your staff. But where it would be different would be if you're changing the core components. So if you're saying, actually, we're not going to do brief regular screening of mental health and drug and alcohol, then I think you're doing something other than the sort of agreed or standardised model of care. I won't go through all the mechanisms of change. You can look at those later on. And at least for now, I haven't put in the measures, the process and outcomes, because that's kind of not the key point where we are just now. Right. So what we did measure was some of those process things. We didn't measure outcomes for some of the reasons that I've talked about before. You know, it was enough in Kath's PhD work that we just wanted to see if we could develop the model, get agreement about the model and get it implemented and see whether people thought it worked. So these are some of the process outcomes that we had. So in terms of acceptability, so there was a lot of engagement from the staff, clinical staff and the team leaders. So 86% of them were engaged throughout the whole process and all the managers thought it was a great idea and were keen to be involved. The mental health residents with a known comorbidity, most of them thought the process of finding a way to integrate outpatient drug and alcohol treatment within the context of their mental health treatment worked really well. 3/4 of them were very happy with that. And all the researchers that were invited to participate, you know, were keen to do so. Even after 4 years of bashing away at this, 40% of the staff who were originally involved were still working on it. And that's, you know, remarkable, I think, in the sense of, A, the longevity of being involved, but, you know, staff go to other jobs and move communities and all that sort of stuff. So to feel have nearly half of the staff working on it 4 years later, I thought was terrific. And as a consequence, or something you might expect because of that high involvement of staff, they also rated integrated care as, or the process of shifting to integrated care for them as being highly acceptable, and also the clients of the services or the residents also thought it was highly acceptable. So the vast majority of them rated it as at least 3 or 4 out of 4. In terms of feasibility, so again, another bit of information that came from the services that I think kind of reflects the problem that we're trying to deal with, and that's that 63% of the mental health clients who got integrated care had never received it before, despite describing long-standing and debilitating co-occurring conditions. So we went from, you know, very sort of haphazard, opportunistic and unknown number of clients in the mental health service who with a co-occurring drug and alcohol problem who got drug and alcohol treatment, to 63% of them getting it in a standardised way. And 328 drug and alcohol occasions of service were provided to those mental health clients just in the first 6 months. Right. So I won't talk too much about this, but I just wanted to flag that the other component of Kath Foley's thesis was to say, the first bit was, you know, we need a model of care. So all the things you talked about with the model of care. And now this one is, how do we make it easier for services, other services to shift from kind of providing independent care to providing integrated care. And these are the pathways, the sort of 3 phases that we came up with. So steps 1 and 2 in the acceptability component is really just about getting commitment from managers, clinicians, and clients about being about the value of this and getting involved and being willing to develop it. The next one is thinking about feasibility. So once you've got everyone on board, how do you co-design that model of care that's going to suit your service and your services? And getting, thinking through how it's actually going to happen in practice. So that's the operationalization component. And then the last phase 3 is once you've got it up and running and you've solved the feasibility things, what do you need to do to make sure it's sustainable over time? So I won't talk about that too much further now. So the second example, so that was the first one, moving from independent to integrated care. The second example is about well, we've done some work recently about improving or trying to improve the cultural competence of non-Aboriginal drug and alcohol services. So again, lots of people involved, and really the impetus for this came from NADA and the PHNs, who thought that there was a great lots of capacity to improve the cultural competence of their services. And then we were approached about helping out with the evaluation of it, which obviously we were very happy to do. So the aim of this project was to optimise the experiences of Aboriginal and Torres Strait Islander clients at non-Aboriginal NGO delivered drug and alcohol services. It was specific in this case to drug and alcohol services, but I think I can't see any reason why it wouldn't apply equally to mental health services, in exactly the same way. So we designed, when we were thinking about what we're actually going to deliver, we co-designed these 5 steps. So we wanted to develop a best practice guideline. We undertook a baseline audit of those services to see how they were going in terms of their current levels of cultural competence against those guidelines. We gave them a report, we held an implementation workshop with them, and then we did a follow-up audit to see if anything had shifted. So here it is again in the program logic. So I haven't specified the areas of focus. Really the key bit here is just to show how those project components again fit into this model. So they're the developing the guidelines, doing the baseline audit and the audit report, the implementation workshops, and then the follow-up audit. So I won't go through all the mechanisms of change. You can look at that when you've got a bit more time. But the key one probably was the implementation workshop. So you can see there, the point of that was to sit down with the services and go through this program logic and say, so, here's what we're trying to do. What are some of the things that you can do? What are some of the activities you could do in the next 3 months? Because that's the only time we had before the next audit. What are some key things that you could do to try to improve within your service, to try to improve the cultural competence of your service delivery? So I won't, we've just hit go on the final report. So it's, we've just sort of finished putting the sort of polish on the outcome services, but we haven't even outcome scores, but we haven't even given them back to services yet. So I won't go through them in detail now, but these are the things we measured. So could we get the first one was, could we get a shift in the audit scores of the services that participated from pre to post-test? And the answer is universally yes. So all of the services that participated increased their level of cultural competence measured by the audit against the original guidelines. So that was terrific. But the thing that really surprised me with that was they showed that increase for the 3 things that they selected, that they thought they could do in the next 3 months. But actually, we also looked at it just for the sake of looking at it on all the other areas where they couldn't improve beyond just those 3. And they showed not a smaller improvement, which you'd expect, but still an increase on those things other than the 3 things that they picked. So that was, surprising and really terrific. The other thing we've measured is, so sure, you could increase activity to improve cultural competence. So A has certainly demonstrated that, but then we wondered whether that would flow through to actually some sort of measurable change for Aboriginal clients. And all of the next ones, B, C, and D. So we looked at whether it changed the proportion of episodes of care that a service provides that are provided to Aboriginal clients. We looked at whether the monthly number of episodes of care to Aboriginal clients changed, and we looked at whether the number of completed episodes of care to Aboriginal clients changed. So all of those things were generally positive as well. So it's really, and all of those outcomes, B, C, and D, are all just based on the minimum data set. So there's nothing in there about did clients, improve on their K10 scores. As we talked about before, that would be, ideal. But there's a lot you can look at and a lot you can measure without getting to that level of detail just yet. So as I say, those services will be available shortly and be very keen and very happy to make them available if people want to see them. But I think this demonstrates that process, can shift what services do, the activities that they provide, and we can demonstrate just using the minimum data set that there's a flow-on impact of those services, in this case in terms of the benefit to their Aboriginal clients. So what are some of the potential benefits of routine evaluation? So this is just a quick sort of summary of some of the things we talked about. So we can systematically and continually optimise the effectiveness of drug and alcohol services and mental health services for the majority of clients. The evaluation techniques are continually utilised, not stop-start, depending on funding or willingness to collaborate. So if you take, for example, the improvement in cultural competence, so we've put a process in place there to be able to measure what the services have done. And we could just walk away and stop, or they could say, well, what if we keep going and try to do some more of these activities? So let's now do it again, pick another series of activities, and then see if that further improves the outcomes for Aboriginal clients. So as I've been saying, we can really kind of think about how do we just continually try to improve things. So we never get to a point where we say, right, now we're doing the best thing ever and we're never going to change, but it's a continual, how do we're doing well now, how can we improve it? The third point is identifying. So really the whole point of this is trying to identify who does and doesn't benefit from service delivery in a real world setting. So we're trying to get away, at least I'm trying to get away from, these tightly controlled, ideal kind of, trials, and say, how do we set up a learning healthcare system so we can say the majority of clients in a particular service benefit from the service being delivered in this way? And if we tweak it a bit, does the proportion of clients who benefit increase or not? And at what cost? So that's the next point as well. Planned and systematic interaction between service delivery and generating new knowledge. So as I hope that framework is illustrated, it's not, there's nothing, what's the word, sort of idiosyncratic about it. It's really sitting down. The hard work is sitting down and saying, what are we trying to do? What's the problem? What are we currently doing now? How might we tweak it? And how do we line up our measures so that they clearly align with what the problem is and what we're doing now? And then the last point there is about the measures being imperfect. So, I kind of often think about, we're all, walking around now with iPhone X's or Samsung Galaxy 20s or whatever we're up to, whatever the numbers are that we're up to, but we didn't start with that. So the first mobile phones were helpful because people could talk while they were out and about. But, my memory of the first ones is they were these bricks that people walked around with. And now we're walking around these things in our pockets that are, much better and much more efficient. So I kind of try to think about that as an analogy. If we wait and say, we don't want to do, better kind of collaboration between evaluating what we're doing and the service delivery, because we haven't yet got the right outcomes, then we're going to be here in 20 or 30 years talking about the same thing and still not have got very far. So I think, personally, I think the minimum data set, there's lots in there we can utilise. And as we go, if we start the process, as we go along, we'll very quickly learn what we need to improve and in what priority. So, I think that the sort of learning's in the doing, and that's a way to really try to ramp up improvements in client outcomes. And that was my final slide. So I use this slide a lot. And I kind of love the look of, you know, sort of indignation between, you know, one wolf and the next about why would you even ask a question about whether what we're doing is making an impact. But I think, you know, the reason that I'm kind of really interested in stuff and trying to do better is because we really kind of be nice if we can be much clearer about the impacts that we're having for our clients. So thank you very much. And I'll now hand back to Susie.
Thank you so much, Anthony. We really appreciate your presentation today. And I think it's given a lot of people food for thought that this is something that we're already doing. We're collecting some of this data. It should be informing treatment. It should be informing how we work with our clients, and we should be providing that feedback to them and the community. So we really appreciate your time today. If you have any questions from today's presentation, do get in touch. Joe will be right there, willing and able to respond to your questions, and able obviously to get in contact with Anthony himself. Please also visit the website. There's lots to be found there, and certainly it'll tell you a little about the next webinar, which is actually all about asking and developing your research questions. So we hope you have enjoyed today, and please tune in to the following events that we've got coming up. Thank you very much for joining us.